Hi everyone, my name is Mathieu Josviak and I am intensivist at Nice University Hospital in the south of France. In the next 15 minutes, we are going to discuss the alternatives to norepinephrine in septic shock. First of all, I have no conflict of interest to declare for this presentation. To date, norepinephrine is the first-line vasopressor recommended by the Surviving Sepsis Campaign in patients with septic shock. And the first take-home message is that alternatives to norepinephrine should be considered only in patients with refractory septic shock. It is only very recently that a clear definition of refractory septic shock has been proposed. Refractory shock is a life-threatening situation in which escalation of vasoactive therapy fails to restore adequate tissue perfusion. And at bedside, refractory shock is defined by the persistence of arterial hypotension and hypoperfusion in the absence of hypovolemia, despite the patient is receiving more than 0.25 micrograms per kilogram per minute of norepinephrine. It is important to keep in mind that this norepinephrine dose threshold is rather debatable, the confusion residing in the way the norepinephrine dose is expressed. So, why consider alternatives to norepinephrine? First, because of the vasopressor load. Indeed, as illustrated in this figure, high-dose catecholamine infusion rates have been found to be directly related to mortality, whatever the specific mean arterial pressure level achieved, due to catecholamine-induced cardiac toxicity with myocardial inflammation and myocardial necrosis. Second, because of the potential immune effects of norepinephrine, which could participate to the sepsis-induced immunoparalysis, which is associated with poorer outcomes. So the question is how to manage a patient with a refractory septic shock. The first step is to rule out differential diagnosis. That is, the persistent hypovolemia, so the presence of preload dependence should be investigated, and the presence of intracavity left ventricular obstruction, which may be favored by high doses of vasopressors. The second step consists of correcting all the factors contributing to refractory shock, as many clinical, biological, endocrine, or metabolic factors can contribute to the onset of refractory shock, both participating in the decrease in vasomotor tone. The third step is to assess left ventricular function with echocardiography. And I'm sure you will agree that the therapeutic response is probably not the same for the patient on the left side of the slide and for the patient on the right side of the slide. In the absence of left ventricular dysfunction, vasopressors should be preferred. The question is which ones to use in these patients who are already receiving norepinephrine. Probably non-catecholaminergic vasopressors that do not use adrenergic pathways, making it possible on the one hand to cope with a reduced sensitivity to alpha agonists and the internalization of adrenergic receptors, and on the other hand to avoid the side effects associated with adrenergic stress, namely the decatecholaminization concept. And this is the second take-home message. Currently, vasopressin is the only vasopressor alternative to norepinephrine in patients with refractory septic shock. The first vasopressor alternative is therefore vasopressin, especially as vasopressin deficiency is observed in almost a third of patients with septic shock and is a risk factor of refractory shock. Vasopressin is synthesized by the hypothalamus, then stored in the post-pituitary gland, and vasopressin exerts pleiotropic effects particularly on blood pressure via its V1A receptors. To date, vasopressin has been studied in two major randomized trials in patients with septic shock. The first trial is the VAST study published in 2008, in which 778 patients with septic shock already receiving norepinephrine were included and randomized to receive additional vasopressor treatment, either by increasing the dose of norepinephrine or by adding vasopressin. The primary endpoint was a mortality rate at day 28. The second trial is the VANISH study published in 2016, which is a double factorial trial in which 409 patients with septic shock were included and randomized to evaluate two therapies: vasopressin against norepinephrine and hydrocortisone against placebo. The primary endpoint was kidney failure-free days during the 28-day period after randomization. In the VAST trial, no difference was found in terms of mortality. However, in a subgroup analysis of the least severe patients, the use of vasopressin appeared to be associated with lower mortality. In the VANISH trial, no difference was found in terms of number of kidney failure-free days. However, there were less use of renal replacement therapy in the vasopressin group than in the norepinephrine group. Finally, in both trials, there was a trend towards an increase in digital ischemia. However, in both the VAST and VANISH studies, the use of vasopressin was associated with a norepinephrine sparing effect and a faster weaning of vasopressors, thereby reducing the catecholaminergic load. How to use vasopressin in clinical practice? A fixed dosage and titrated on clinical response should be considered, and vasopressin is contraindicated in patients with ischemic diseases. The remaining question is the appropriate strategy for tapering vasopressors in patients receiving both vasopressin and norepinephrine. This meta-analysis, including 8 studies, found conflicting results, with a single randomized trial favoring stopping vasopressin first, and the 7 retrospective studies favoring stopping norepinephrine first in order to avoid arterial hypotension. Therefore, the strategy for tapering vasopressors has yet to be confirmed. What about the synthetic vasopressin analogues that have greater selectivity for V1A receptors, namely terlipressin and celepressin? Trials of each have been stopped for futility, and their use may be associated with more ischemic adverse effects. The second non-catecholaminergic vasopressor that could be of interest is angiotensin II, especially since, as with vasopressin, some patients with septic shock have an angiotensin II deficiency. This was tested in the ATHOS 3 trial published in 2017, in which 344 patients with refractory septic shock were included and randomized to assess the effects of angiotensin II addition against placebo. The primary endpoint was the proportion of patients with a mean arterial pressure above 75 millimeters of mercury, or who had an increase of more than 10 millimeters of mercury in mean arterial pressure without increasing the dose of norepinephrine. As you can see in this figure, the addition of angiotensin II significantly increased mean arterial pressure, but 30% of patients were non-responders. Nevertheless, the administration of angiotensin II was associated with a norepinephrine sparing effect, thereby reducing the catecholaminergic load. It should be noted that there was no effect on mortality and no increase in serious side effects with the use of angiotensin II. Interestingly, in a post-hoc analysis of the ATOS-3 trial focusing on patients who required renal replacement therapy, angiotensin II administration was associated with a reduced mortality and also a faster recovery of kidney function. Overall, angiotensin II could be an interesting option, but we still lack evidence. Patient phenotype and optimal dosage of angiotensin II have yet to be better identified. It is therefore currently recommended that vasopressin be added in patients with refractory shock without left ventricular dysfunction. In patients with left ventricular dysfunction, inotropes should be preferred, and ear intensivists has a choice between adding dobutamine to norepinephrine or introducing a treatment with epinephrine alone. To date, what the literature shows is that there is no difference in terms of mortality between the combination of norepinephrine plus dobutamine or epinephrine alone. Furthermore, there is no demonstrated superiority of dobutamine in terms of achieving hemodynamic objectives or the duration of catecholamine weaning. Therefore, the choice between these two strategies is based on the side effects and availability of the two molecules. On the one hand, epinephrine has more marked adverse effects, such as tachycardia and metabolic acidosis. On the other hand, epinephrine is more readily available in developing countries. Thus, given the adverse effects of epinephrine, it is currently recommended that dobutamine be used as a first-line inotrope in patients with refractory shock and left ventricular dysfunction. In patients with the most severe left ventricular dysfunction, veno-arterial ECMO should be also considered. The third and last take-home message is that steroids administration should be associated with vasopressors, especially as adrenal and or corticotropic insufficiency could be a factor in refractory septic shock. Two major randomized trials have recently evaluated the effects of corticosteroids in patients with septic shock. The French APPROACH trial, which tested a strategy combining hydrocortisone and fludrocortisone, and the adrenal trial led by ANZIX, which tested hydrocortisone alone. Both trials had the same primary endpoint, which was the mortality rate at day 90. APPROACH trial showed a decrease in mortality, which was not the case in the adrenal trial. Both trials also found more frequent metabolic adverse effects with corticosteroids. But more importantly than the effect on mortality, that's the fact that the two trials showed that corticosteroids enabled faster weaning of vasopressors. Finally, it remains to be seen how soon vasopressin and steroids should be started in patients with refractory shock. Should we start as soon as patients receive a certain dose of norepinephrine? Or should we wait a few hours and decide on the basis of the patient's evolution? There is currently no clear answer in the literature, and this question requires further study. It therefore seems reasonable to follow the recommendations of the Surviving Sepsis Campaign, which recommends starting vasopressin as soon as the dose of norepinephrine is greater than 0.25 micrograms per kilogram per minute, and which recommends starting corticosteroids if the dose of norepinephrine is greater than 0.25 micrograms per kilogram per minute, and it has been more than 4 hours since norepinephrine was initiated. Thank you very much for your attention.